Good afternoon, everyone, and welcome to this session, the last session of the academic year. My name is Alfred Lardizabal, and to this afternoon we have another session focusing on ocular manifestations of tuberculosis. Our speaker today is Augusto Dulanto Chang, who is a second-year clinical infectious disease fellow at the National Institute of Health. He is accompanied this afternoon by Adrian Schaller, who's ID at Georgetown University Hospital, as well as Tara Palmori, who's ID at the National Institutes of Health as well. This is a good follow-up to the last session we had, which focused also on ocular manifestations, and I hope that we will have a good discussion at the end of the presentation with all the experts who are available online. So, Augusto, without further ado, please go ahead and start your case. More than meets the eye, tuberculosis, uveitis, and paradoxical reactions to miliary TB.
Hi, Dr. Dulanto, you're muted. I see you have to unmute your line.
It's *6.
Star 6.
Okay, hello. Can you hear me now?
Yes.
Okay. Thank you very much, Dr. Lardizabal, for your introduction. And I'm going to then move forward with the challenging case that we saw with Dr. Schaller. That will be the focus of this presentation. Okay, so this was a 75-year-old male from Bangladesh who initially presented with a 2-month history of redness on his right eye, as well as mild pain and a worsening vision on the same side. He initially saw an outside ophthalmologist who diagnosed him with uveitis and prescribed him a steroid eye drop that he used every 2 hours for this diagnosis of uveitis. However, his symptoms didn't improve, and actually he had progressive vision loss over the 2 months. He followed up with his uveitis doctor, who told him that he needed surgery. However, he declined, and in that context, he was referred to the NIH uveitis clinic. For review of systems, he denied any fever, weight loss, night sweats, or cough. He had some stable shortness of breath on climbing 1 flight of stairs that was due to his underlying cardiac comorbidities, and otherwise his review of systems was remarkable. His past history was relevant for coronary disease with PCI that was done in the US in 2014. He also had a chronic LV thrombus with an aneurysm. It was not an anticoagulation at that point, and an ejection fraction that was low, 20 to 25%. He was taking his heart medications as well as some his steroid eye drops, but otherwise he was not on any other relevant medications. His social history was a bit more interesting. He was from Bangladesh, but he moved to the US in 1994. He still traveled back and forth, and his last trip to Bangladesh had been 4 months prior. He lives in North Potomac, Maryland. He denied any pets or contact with animals, and he was a former mechanical engineer, reportedly monogamous with his wife. On his physical exam at the uveitis clinic at NIH, his vitals, besides being slightly hypertensive, were unremarkable. The most relevant on exam was that his visual acuity had no light perception on the right eye, as well as a 1+ conjunctival injection on the same side. The left eye was relatively spared, and the rest of his exam, including respiratory auscultation, was unremarkable. I'm going to show you here a close-up of the patient's left eye. This was an affected site, and it was described as normal with just a mild cataract. And this is in contrast to this patient's right eye. And on inspection, it was revealed that he had some large creamy nodules on his iris, as you can see here. as well as irregularly shaped pupil. On a close-up, these creamy nodules were described as iris nodules or granulomas. It was also appreciated that the cornea had some white cell deposits or kerratic precipitates. Due to the size, they were termed mutton fat kerratic precipitates. Finally, this irregularly shaped pupil was explained by some addition of the iris posteriorly onto the lens, generating posterior synechiae. Here we can see also the slit lamp examination that showed even more clearly the deposition of clumps of white cells on the innermost layer of the cornea, as you can see, as well as haziness on the cornea and the anterior chamber due to the protein or inflammatory cells accumulation. This is the fundoscopy of the left eye. This is again the unaffected eye. The marked inflammation on the right eye did not allow for visualization of the fundus, but on the left eye it was unaffected. So based on all these findings, he was given the diagnosis of spine uveitis of the right eye. And we're just going to go quickly as a reminder about the uveitis. When we're talking about uveitis, it can be classified in anterior, intermediate, or posterior, depending on the localization. It's also called iritis or iridocyclitis, and it presents with pain and redness at the limbus, and it can sometimes be infectious, but it's not very common. Intermediate uveitis refers to inflammation of the vitreous without flank posterior choroiditis, and it's very rarely infections, more often related to other autoimmune conditions. Posterior uveitis, on the other hand, it's also called chorioretinitis, and it usually manifests as floaters or decreased visual acuity because it's usually painless. And this is the most common type of uveitis that is caused by infectious etiologies. When there is involvement of both anterior and posterior chambers, this is called panuveitis, as in this case, and it can also be often infections. And here I'm just showing the different etiologies of uveitis by localization with the infections agents in yellow. And I wanted to point out how the most common etiologies when we think of chororetinitis, such as CMV or toxoplasma, are located in the posterior uveitis section. Tuberculosis can potentially involve any eye structure, but most commonly causes, when it causes a uveitis, a posterior or a panuveitis. So moving along with our case, this patient had some basic lab work done. His complete cell count and basic chemistries and liver function tests were normal. He also had a basic rheumatologic workup that was only relevant for elevated inflammatory markers. His toxoplasma serology was consistent with past infection, and he had a negative test. He also had a positive or strongly positive quantiferin TB gold, as well as a tuberculin spin test. He had a negative chest X-ray, but given the high suspicion for TB, due to his TB test and his epidemiology, he underwent a CT scan of the chest, and this revealed, well, the report said, scattered, poorly defined lung masses and focal infiltrates. As you can see here in the apex, they were spread all over the left lung and also on the right and the left lung, and especially the left base. There were many other poorly defined radiodensities, 2 to 3 millimeters in size, and you can see here pointed by the arrows, labeled as pre-blood infiltrate. And this lesion on the left base here. So because of these lung findings, he was asked to provide sputum samples ×3, which were both negative for AFB smears and also culture. And surprisingly, he did agree to have an anterior chamber tap to confirm the diagnosis. And to everybody's surprise, he only had 20 microliters submitted to mycobacterial culture. But only in 9 days, this returned positive for tuberculosis that was confirmed with a TB expert on the culture media. He also had toxoplasma, panfungal, and panbacterial PCRs that were negative from the vitreal fluid. So with these, the diagnosis was confirmed as tuberculous panuveitis. So I'm not going to review in depth this topic since we had a recent discussion about TB uveitis. I'm just going to go quickly over some general features. The pathogenesis is thought to be hematogenous spread from a pulmonary or extrapulmonary site. The incidence is unclear. Some reports have a reported incidence of 1.4 to 15%, but it's unclear for a few reasons. In part because this diagnosis tends to be done mostly as a presumptive diagnosis and not confirmed with microbiology. And the presentation tends to be subacute or chronic and often presents after vision loss. Sorry. And some important differential diagnoses with granulomatous uveitis are sarcoidosis and syphilis. So I'm going to show you some images. I'm going to show you some images of the most characteristic ocular exam findings for granulomatous uveitis. This is when there is anterior uveitis, there tend to be keratotic precipitates that are leukocyte deposits that precipitate on the posterior layers of the cornea. In the cases of granulomatous uveitis, these keratotic precipitates are large and are called mutton fat. These are other findings in anterior uveitis, like anterior chamber granulomas, sometimes termed iris nodules. And when the inflammation of the iris causes adhesion to the lens, this can cause an irregularly shaped pupil, and it's called broad-based synechiae. Some findings in the posterior chamber. You can see sometimes choroidal tuberculomas. There are tuberculous abscesses in the choroid in the posterior part of the eye, and sometimes this can enlarge and precipitate a retinal detachment. There can also be retinal vasculitis and inflammation along the retinal vessels, which when chronic can result in hyperpigmented geographic scarring that has been named serpiginous choroiditis. So how good are these ocular findings at predicting tuberculosis? The best evidence comes from a series of 308 patients. These were patients from India. 182 of them had tuberculosis as a suspected case for the uveitis. And we have to keep in mind that this was a high prevalence setting and the diagnosis was presumptive and not microbiologically confirmed. Oh, I don't know why my slide advanced on its own. But with these caveats, the conclusions were that even though many of these signs or symptoms were not that great in their diagnostic accuracy, the presence of base synechiae, retinal vasculitis, and serpiginous choroiditis probably had the most diagnostic utility. Although the numbers, as you can see, are not also that great. So a quick word about tuberculous granulomatous uveitis diagnosis. Worldwide, the diagnosis is still largely presumptive, since only a minority of patients undergo vitreal fluid testing, and even when they do, the yield of culture and molecular testing is suboptimal. So most commonly, the diagnosis is based on clinical findings of uveitis plus extraocular TB, or uveitis plus a positive latent TB test, or uveitis in the setting of in a high prevalence setting. Cultures and molecular testing have suboptimal sensitivity, and I'm going to talk a little bit more about that in a second. The treatment, unfortunately, there is no consensus about what regimen is best to use and what duration to use. However, it might be reasonable to avoid ethambutol if there is prospect for recovery of vision, and because it is difficult to monitor for optic neuritis with this agent and these patients. Some literature cites attempting a treatment trial, but it's difficult to assess what would constitute an appropriate response to the treatment, and at what point in treatment we would be able to say that there has been a response or not, since the natural history of TB uveitis on treatment has not been well established. So most likely, once you start somebody in empiric treatment for TB uveitis, you would have to finish the course. So a little bit about molecular testing. In the case of our patient with the high bacillary burden, it was evident since only 20 microliters yielded a positive culture in only 9 days. But the sensitivity of molecular tests on direct specimens from vitreous fluid is quite low. In general, it's up to 77% with a homebrew PCR in one of the studies. But from the commercially available tests, the highest is 70%. As far as I know, the new Expert Ultra has not been evaluated in vitreous fluid, but it's supposed to be more sensitive. Some general pros and cons of molecular testing. On one hand, we have that the sensitivity can be suboptimal, and it's depending on several factors, such as the organism load, the number of targets on these PCRs, for example, and possible presence of interfering substances in the sample. However, they usually have very high specificity and fast turnaround time, especially when compared to cultures. And they allow sometimes for identification of resistance. And in theory, they can detect organisms that are dormant or non-viable. So back to our patient. A few days later, this patient presented again to the clinic with a sudden onset of severe eye pain with lid edema and swelling, as you can see in these pictures here. He had no orbital signs, so it was thought maybe he had preseptal cellulitis, and he was prescribed cephalexin for 10 days. However, there was no improvement, and at this point, the culture result was not back yet. But he was started on right empirically at this point. And again, it was discussed the possibility of enucleation for him, but he declined for a second time.
This is in line.
A week later, however, the redness on his eye persisted, and now it was associated to headaches. He had an MRI of the orbits with an orbit specialist, and also the result was disclosed to him that he had multiple brain lesions and was advised to seek care for that. However, he declined this as well. This is the MRI of his orbits, and this was day 8 of RIPE. And you can see here there were some small scarred foci of T2 hyperintensity in both parietal lobes and as well as the cerebellum, with some contrast enhancement that is not shown here. So as I mentioned, he was advised to go to the ED, where he declined. But 2 days later, while he was at the Department of Health providing or getting his directly observed treatment, his daughter received a phone call saying that her dad was altered, he was tired, and he could not stand up, as well as he continued to have eye redness. Per the daughter's report, his temperature was also measured, and he had a fever to 101. So he was immediately taken to the Georgetown Hospital emergency department. At Georgetown, a repeat MRI of the brain showed, again, miliary brain lesions. Because of this worsening mental status as well as headaches, he was started on IV dexamethasone for the possibility of CNS tuberculosis. He had an LP, which was normal in cell count, protein, and glucose, however, it had a slightly elevated opening pressure. But the AFB cultures from these were negative, as well as other bacteria, fungal cultures, and cryptococcal antigen. Also, during this admission, it was found to have myopericardial involvement, initially detected through some alteration troponin, KG abnormalities, and a cardiac MRI was done. Because of the concern for pericardial, also give him a more extended steroid taper. He also had an elevation in his transaminases during this admission that was thought to be drug-induced. So his tuberculosis regimen was adjusted, and pyrazinamide was stopped. Eventually, he was discharged on rifampin, INH, and levofloxacin, as well as vitamin B6. And his steroids were changed to prednisone 60 milligrams daily. This is the cardiac MRI. The report mentioned fibrinosus stranding with loculations and adhesions typical of TB. And this is the MRI of the brain that he had in Georgetown. I wanted to point out here the inflammation noted in the right orbit as well as the right lacrimal gland when compared to the other side. There were also numerous stable enhancing foci in the bilateral cerebellum and in the supratemporal juxtacortical white matter. Okay. Finally, the MTB susceptibility came back. So since he had been on appropriate therapy, this worsening of his picture was deemed to be a paradoxical reaction to his anti-tuberculous treatment. So I'm going to talk a little bit about that. When comparing HIV patients versus non-HIV patients, paradoxical reactions are less frequent in the HIV negative. And since this is probably because they occur in a different setting, since HIV patients usually have paradoxical reactions in the setting of ICE after starting HIV therapy. Oh, sorry about that. Non-HIV patients experience paradoxical reactions as well, but much less frequently. One study compared the frequency of paradoxical reactions in 33 HIV patients, comparing them with 55 non-HIV patients. And it was seen that the incidence was 2% in the non-HIV group. I'm sorry. Oh, I apologize for that. It's not TB, I swear. So it was 2% in the non-HIV group versus 36% in the HIV positive group. However, they didn't have enough numbers in the non-HIV to better characterize the clinical findings. A larger study, however, characterized the clinical manifestations of paradoxical worsening. This was a retrospective review of 76 patients with extrapulmonary TB. They defined paradoxical reaction as an initial improvement followed by a worsening of or new lesions. And in this study, the incidence was found to be 25%, which was higher than the previous report. But this study included extrapulmonary TB, and the definition was different. The onset was very variable. Oh, sorry about that. The most common manifestations were lymphadenopathy in 68%, new long lesions, 10%. And of note, 15% presented new lesions other than in the primary site. In this case series, 47% required corticosteroids and 15% an additional intervention, such as surgery of lymph node removal or collection drainage. And the TB treatment had to be modified or extended to 21%. However, one thing notable about this study was that the outcome was usually very favorable with corticosteroids. Unfortunately, there is no guidance for management of the paradoxical reaction of TB in non-HIV patients. There's usually good response to steroids. Sorry about that. The described doses are also variable and depend on the localization, but the median was 0.5 per kilogram. The range was wide between 0.05 milligrams per kilogram per day to 1 milligram per kilogram per day of prednisone or equivalent, and sometimes require prolonged tapers. One thing to keep in mind in these cases is that rifampin can decrease the steroid bioavailability. And thus, when you start or stop rifampin, this can modify the effective dose of steroid. There are some reports, and this is all non-FDA approved indications and a case report basis, but there are some other non-steroidal agents that have been described in tuberculous paradoxical reactions. Most of the literature is in TB IRIs related to HIV. But you can see here some of the agents that have been used with some success include thalidomide for lymphadenopathy or intracranial tuberculosis, montelukast also for septic meningitis or lymphadenitis, and infliximab or adalimumab have also been used for in lymph node enlargement or intracranial tuberculosis. And finally, pentoxifab has also been described. So finally, in the particular case of TB uveitis, there is not much information about TB uveitis being a manifestation of a paradoxical reaction who were not known a priority to have TB uveitis. I found one case report, and I know that there can be a couple more, but it's not something common. However, in cases of TB uveitis, there are multiple reports of initial worsening after initiation of therapy, and one of the most concerning manifestations is retinal detachment. The onset also has wide range, goes from 4 days to 5 months in the reports. And it is also usually responsive to steroids, although the doses used on the taper regimen are unclear. When these manifestations have been steroid refractory, there are also, again, in the case report basis, a couple of other agents that have been used. Intravitreal injections of bevacizumab, which is a monoclonal antibody directed against the growth factor, has been described in cases of retinal detachment associated to posterior choroidal tuberculosis. Another possible treatment is intravitreal injections of methotrexate that has been used to decrease the inflammation seen in serpiginous light choroiditis in at least a couple of case reports. So just to give some today follow-up on our patient. He was on effective treatment since about February 2017. Since he had no expectation for visual recovery, he was offered by 3 different ophthalmologists and also infectious diseases the possibility for enucleation. However, he perpetually refused, and in the end, he might have been right because with a very prolonged steroid taper, he so far has been able to keep his eye. In March of last year, he had a second episode of drug-induced liver injury, and his tuberculosis regimen was adjusted once more. He ended up being on ethambutol and rifampin as well as levofloxacin. However, because of the possible concern for side effects of ethambutol and levofloxacin in this patient in particular, he was re-challenged with INH and rifampin, and this time he tolerated it well since April of last year. He finally completed 12 months of treatment with rifampin until end of March of this year. His steroid taper was very difficult, as I'm sure that maybe Dr. Scholler would have more to say about this, but initially he was 60 milligrams a day of prednisone for 4 weeks, and the plan was to taper it to 30 for 4 more weeks and then 15 for 4 more weeks. However, as soon as he reached 15, he developed again very severe headaches and lethargy and ocular inflammation. And his dose had to be readjusted up all the way to 40 milligrams BID. With this, there was improvement on the inflammation. However, the taper was were unable to taper the doses. Surprisingly, the intervention that seemed to make it easier was that the ophthalmologist added topical steroids to his treatment, and with this, the taper was able to continue very rapidly. He finished his taper around September of 2017, and he hasn't had any additional episodes of increased headache or inflammation. Because of these headaches and lethargy, he had a repeat MRI of the brain to assess the resolution of his CNS tuberculomas or worsening, and in June of last year, it was seen that all the lesions were gone. So this is where he is now. He's completed his TB treatment. He's not on steroids, and so far he seems to be doing well. But of course, he didn't recover the visual acuity, which was not expected. So in summary, we had a 75-year-old male from Bangladesh who was he was also noted to have miliary TB with involvement of the lung, CNS, and pericardium on further evaluation, and presented a worsening inflammation with treatment, both in his eye and CNS manifestation, but eventually improved with a very prolonged steroid taper and completed treatment. Some take-home points were in the part TB uveitis. To remember, this is a granulomatous inflammation characterized with mottled fat, sporadic precipitates, iris nodules, broad-based synechia, retinal vasculitis, and sometimes serpiginous choroiditis are typical findings of TB. And worldwide, this is still predominantly a presumptive diagnosis despite the advanced diagnostic techniques. Actions to treatment in the HIV negative are less frequent and have usually better prognosis. and the onset can be variable in the HIV-negative patient. And response to corticosteroids is usually excellent, except for a few cases in which there is CNS involvement. Okay, and well, that's my presentation. I'm happy to answer any questions you have.
Oh, Augusto, thank you so much for the presentation and a very complicated case, and you finished it in 30 minutes. That's great. I'm sure there's a lot of folks with questions out there. Before we open the floor to questions, any additions to or comments to the case presentation, Dr. Schaller or Paul Maury?
Can you hear me?
Yes. Oh, hold on. We can't hear you now.
Okay, what about now?
Yeah, go ahead.
Okay. The main thing that I took away from this, although of course it's very anecdotal, is that the steroid taper had to be very, very, very slow. I initially tried to do it too quickly, and then ultimately, once he hit about 20 milligrams, I had to come down by about 2.5 milligrams per week in order for him not to have symptoms. And even then, I would occasionally have to go back up and then reattempt to taper him back down. Otherwise, he would present with sort of his typical symptoms of sort of the periorbital inflammation, severe unilateral headaches that we didn't think were from any other reason because we already had that MRI showing that the rest of his CNS disease had fully resolved. So that was one major thing that I took away from this case. And that was really the only other comment I had, apart from the fact that temporarily it was very odd. We really couldn't get him down from 40 BID, and then all of a sudden he started ocular lubricant and ocular topical prednisolone, and within a few days he started to feel better. And all of a sudden, when I had not even been able to take him down from 5 milligrams off to 40 milligrams, I was suddenly just able to taper him actually quite beautifully on a weekly basis. So I have no idea. I couldn't find any actual evidence for a role for topical steroids beyond systemic steroids, and it seems a little bit unbelievable, but temporarily there was a very strong association.
So in this case, there was certainly infection of the eye that seems to be microbiologically confirmed. The paradoxical reactions occurred with regards to the headaches and the sort of meningeal symptoms and eye swelling. Is that where you thought the paradoxical reactions were occurring?
Right, he had fever, high ICP, and very, very obvious. I think you saw the original pictures of like quite significant preseptal inflammation around the eye. There was also lacrimal inflammation on the MRI, which then resolved almost immediately with steroids. Yeah. And that was the reaction that was coming back. It was the sort of very visible ocular inflammation and inflammation of the periorbital tissues associated with headache.
Right. So, any questions from our audience or comments from Dr. Frema, who discussed the same topic a couple of weeks ago? *6 to unmute.
Yeah, hi, this is Henry. Thanks for a great case presentation. I've heard bits and pieces of this case during the course because this was actually a case that came through the medical consultation line. But it's actually really nice to hear the whole story laid out in sequence. I mean, this is interesting and atypical because, I mean, clearly he had a very high burden of disease in his eye. The fact that his cultures were positive with such a small volume of fluid and grew so quickly suggests that his inoculum in the anterior chamber must have been really high. Usually, and I think from the data you showed as well, making a diagnosis of eye disease is often much more challenging. And I guess that suggests that he, besides having a lot of disease in his eye, he had more extensive disseminated disease than was realized. And it looks like he had a lot of foci on his brain imaging as well. Most of the cases, the uveitis cases that we either see or hear about, we almost never have somebody who has a positive culture, so that's very impressive.
Yeah. Well, that brings me to my question, at least I'm sure some people are wondering. In this case, the workup proceeded to tapping the eye and getting some fluid, which eventually confirmed the suspicion. Oftentimes, this type of intervention isn't performed. As a take-home from this case, what situation would trigger a more invasive sampling? Was it the fact that you saw granulomas inside the eye? Those are the things that we're trying to figure out, since the approach to uveitis seems to be varied.
I think that's a great question.
Oh, sorry.
Sorry, go ahead.
No, go ahead.
What I was going to say is that in this particular case, I think one of the we decided to proceed to get sampling is that well, this was a very particular patient, and he, as you saw, he declined many of the possible interventions that were offered to him. I think we were not going to be able to convince him to undergo a full course of TV treatment without more diagnosis, even though he was high baseline, so probably wouldn't necessarily need to proceed with that.
I think because your audio is
hello.
I mean, it's
Go ahead, Henry.
Yeah, I mean, I somehow suspect the fact that he was seen at the NIH uveitis clinic was a major driver in why he actually had more diagnostic testing done. I mean, from our experience here, it seems like this has become a much hotter topic among uveitis specialists than it used to be. And I don't know if you got any sense of that from the folks from the NIH clinic, but just looking at the pattern of referrals that where we're seeing these patients, it seems to be primarily the folks who come from Wills Eye Hospital and the uveitis clinic there. And from reading the literature, it seems like at least the uveitis specialists are much more attuned to this. That doesn't mean that they all go on to have sampling, but at least this seems to be a diagnosis that ends up being higher in their differential. And I mean, I don't know if Dr. Sundstrom is on the call, but the data that he shared with me from Michigan just about the proportion of their extrapulmonary TB cases that now fall into the uveitis category and are treated whether with or without cultures has now become, I think the numbers were almost a third of their extrapulmonary cases, which just tells you that somebody's making these diagnoses. And I think we don't even capture all of these, because if they're diagnosed and treated out of the health system, then they probably, and there's no microbiologic data, they never get captured as diagnoses of TB uveitis.
Right. So a lot of times the patients I get don't go through this. They have a positive IGRA perhaps, and then they have a red eye, and they get treated as a TB uveitis, and that's about it. So it's an interesting topic that you raised, Henry, that there seems to be, at least in Michigan, an uptick of these types of presentations in terms of involvement of the eye, and I would be curious to really get a bigger sampling of whether this is indeed true across the U.S. We certainly don't report probably as accurately the occurrence of specific TB of the eye involvement in terms of how they're reflected in the surveillance data. I have the other aspect of this case that I found interesting was the fact that the patient was quite steroid dependent, and you did bring up, Dr. Delante, you brought up a few other ways to handle the host reaction, including monoclonal antibodies, thalidomide, and all that. This is another aspect of TB management that isn't focused on as much, probably because they don't happen a lot, but they do happen. And when they do happen, it's very difficult to manage. Have you come across anything in your review that kind of identifies the phenotype sort of genetically that would be that would behave this way, wherein they'd be steroid dependent, they'd be hyperinflammatory, whether it's TB of the lymph node or TB of the meninges or some other extrapulmonary part. Some even with pulmonary TB can be can exhibit a highly destructive process, and I'm not sure we have an identification or a marker that would help us tailor our approach.
Oh, Dr. Isabel, I think that's a great question, and it's a matter of much investigation, especially here at NIH. In particular, in HIV patients, where this happens more often, they are following a large group of patients here, trying to identify these particular kinds of predispositions to, in a way, a hyperactive immune system with iris. But as far as I can tell you right now, I think we have identified one factor that is very strong. Very strongly related. So it tends to be a little heterogeneous. I know that they have been trying different therapies based on what they have found through different studies. These TNF-alpha, for example, monoclonal antibodies are directed against the TNF-alpha mediated response that is sometimes altered in some of these patients. And something else that is also, I think, is still in the works. For some patients, they have seen the alteration of JAK-STAT, and they are trying to focus the use of JAK inhibitors and for also TB-iris. But I don't know if this is something that has been well defined yet. I'm not sure. Dr. Eunice Soretti here is who probably knows best about it. I don't know if she's on this meeting.
Right. Yeah, if you're on the line, that's *6. But most of the time when we come across these patients, it's almost like a trial and error as you add with this patient. Like you bring it down nice and slow until you hit the wall, and then you have to go back up. And I think that at this point is how most of the clinicians handle the hyperreactive patients. There are occasions when this would happen with the pediatric patients too, wherein they would have this lymph node that would involve the mediastinum over time. While you're treating the small lymph node, the mediastinal nodes start to swell, and then you'll decide to kind of use anti-inflammatory agents like systemic steroids. But I think most of the time we just stumble upon these sort of paradoxical reactions and deal with it when they do present themselves. Any comments, Henry, with regards to patients you've had
Yeah, I think so. I think we're kind of used to seeing this with lymph node disease, and my guess is maybe 1 in 10 or more of the lymph node patients have paradoxical reactions. And I think most of the time, because unless it's in a bad place, those paradoxical reactions don't contribute to huge morbidity. You know, they sometimes respond pretty well to low doses of steroids. They rarely need more aggressive treatment. The brain lesions, however, are the ones that are most problematic. And, you know, the incidence of paradoxical CNS lesions probably underreported in studies that, you know, have systemically done MRI imaging or other imaging in anyone who has disseminated tuberculosis. The incidence of CNS lesions probably a lot higher than expected. So the paradoxical CNS lesions are very problematic, and those are the ones that the steroids tapers have to be very slow. And, you know, I think I don't think we fully appreciate the toxicity of high doses of steroids in some of these patients, particularly our older patients, particularly our diabetic patients. And so having a better sense of when alternative anti-inflammatory regimens might be appropriate to get these people off of or on lower doses of steroids would be a huge help in their management.
I agree. You know, steroids are used very easily. We're very comfortable with it. They may not be the best. There may be more targeted ways of controlling inflammation, but I don't think we know much more than what we know today. If you came across anything over at NIH that would say, well, thalidomide may be better, or you know, the monoclonal antibodies might be better, most clinicians are a little hesitant to jump there because they're just simply not it's not used frequently. But it's my sense that maybe there are other agents that are more appropriate for specific situations.
So my one comment about that is that I have frequently used thalidomide, not for TB, but for Mycobacterium leprae, so Hansen's disease, to manage type 2 erythema nodosum leprosum reactions, and it does have that sort of anti-inflammatory property. Most clinicians, I think, would have difficulty using it because it is very difficult to get a hold of. Not so much for the established use of leprosy, but most likely for other things that have sort of very strict approval criteria and follow-up.
Right.
And I guess the one other comment about this case, we were lucky in his instance. He didn't have any particularly bad side effects from the steroids. There was some borderline steroid-induced hyperglycemia and a little bit of a cushiony appearance that eventually resolved itself, and some minor mood changes, but he was relatively okay. What we really struggled with was trying to decide whether or not we should. We did try to push him to consider enucleation just because he was steroid dependent at very high doses, effectively to try to manage intraocular pressure surrounding an eye that had no light perception. So there was no prospect of visual recovery. But that was something that he repeatedly declined on a cosmetic basis. I think if we'd failed in the final taper, we were going to really try to pursue a third opinion with another ophthalmologist. But all of us had a consensus at the time, when we had him on 40 BID of prednisone, that we should really be looking at enucleation. Fortunately, in the end, he ended up being right and he did fine.
Great. So the final result is blindness of the right eye, and the swelling is down. No more headaches.
Correct.
Great.
The patient's actually in Bangladesh right now, but he sent me an email saying that he's feeling entirely well.
Great.
Back in August.
Any other questions on the line? There's some good number of people who are listening this afternoon. Henry, any other comments?
Yeah, I guess one question. So the only place that he ever grew was from his eye, is that correct?
Yes,
Hello?
that's correct. The only culture we had positive was from the eye, but the other samples were mostly respiratory, were all negative for tuberculosis.
Right. So, I mean, it is even more lucky that they went ahead and sampled the eye at the beginning of this process, because had you been halfway down the road with no cultures and what you think is a paradoxical reaction, but you also haven't excluded drug-resistant disease, it becomes even messier. So, again, the lesson there is, if at all possible, if we can work out some, strategy with our ophthalmology colleagues to sample when possible, to at least help us to, make sure that downstream we have appropriate treatment. This guy had toxicity issues. You could have been worried about drug resistance if he had a paradoxical reaction and you didn't know he was on appropriate therapy. Could have ended up on a really messy, complicated regimen. So it's very lucky that they did that.
Yeah, you're right. If we didn't have the susceptibility results, we would have been scratching our heads whether this was resistant or otherwise, and would have a more complicated management course. Well, let's find some of our ophthalmology colleagues who would be willing to do more of these taps. But fortunately for you folks in Bethesda and DC, you have access, or seem to be willing to tap the eye more than most eye offices. So, any other comments? If not, we are winding down the afternoon's meeting. Thank you again, Dr. Dulanto and Dr. Schaller, for participating and presenting this excellent case this afternoon. Please note that this is our last session for TB Grand Rounds for the 2018 academic year. We'll be taking a summer break, and Grand Rounds will resume again in September after the summer break. Thank you, have a good day, and have a good weekend.
Thank you.
Thank you. And actually, just like to say a quick thank you to Dr. Framo. His advice with this case was really invaluable. I don't know if you heard that or not.